Thank you. So I will, it's not a change of focus, but the idea of this was that it should be a bit more practical. So following my short introduction to this topic, my good colleagues from Denmark, Lise Kronborg and Jan Overgaard will follow. And there will be at least one of them will do some practical things up here. So we look forward to that. So resistance exercise, if we and how to do it in the clinical practice. One of the things that we want to, well, handouts should be available, I should say, later on. And but one of the things, if you want to do strength training, resistance training, you might also want to measure how well are they doing. And for that, you can use different methods. And since we are in Oxford, and I looked this up, and actually I didn't know it was related to Oxford. You might be familiar with that, but the 0 to 5 grading, which is the simplest form of testing muscle strength, and that's for the weakest, of course, because you can go from just a flicker of movement to full range actively against strong resistance. So it goes all the way up, but it's difficult to quantify. How strong are you? And it might depend on the person putting on the resistance. So another easily doesn't require any other equipment that weight loads. And you could try, if you're weak, this is a hip fracture patients in hospital, and they are not able to move that much weight loads. So if you want to find out how much weight can they actually move one time, you might have to load up to 10 kilos. But for most of these patients, for the fractured limb, they will go much lower than that. But you also could try to more repetitions, up to 10 repetitions. How much weight can you lift 10 times? But maybe 6 or 8 is more appropriate. So, but it's something that can be used in clinical practice if you don't have other equipment, and also you can use it at the hospital ward. Of course, all other training machines can be used. And then you have a bit more advanced equipment, not that advanced, but the handheld dynamometer, which you see it's applied down here, and then it's fixated to avoid this, that it's depending on who is holding against the person straightening the leg. And you get a report in Newton, and you can convert it to Newton meter or Newton meter per kilo, or just Newtons per kilo. So, and that's isometric strength. So if you want to see how much power they are able to produce, the Nottingham power weight is quite popular. I guess it was invented in Nottingham. Or by Mr. Nottingham, I don't know, but it's you will see it's commonly reported in some studies, especially in the UK. And so I looked into some studies. How are these hip fracture patients actually doing in the early stage after fracturing the hip? And the blue one is the latest study that I did in 2009. And what we found was that the strength in the fractured limb was reduced with more than 50% compared to the non-fractured limb. And that was about 1 week after fracture. And then I took the liberty to calculate the same figures for some studies by Professor Lamb, Mitchell, and Sherrington. And altogether, no matter if it was power that was assessed or isometric strength, the strength was below 50% in the fractured leg. So, and in the power assessment, it seems like it was reported that the hip pain was a restricting factor, while we found in in the blue line that it was especially related to trochanteric fractures and the amount of edema in the fractured leg. So the more edema, the more the strength was reduced, and markedly larger in trochanteric compared to cervical fractures. So this was putting it all together. And you might ask, well, does it matter, the strength thing? And Professor Lamb actually reported that the leg extensor power was the strongest determinant of walking speed and stair climbing time. So it seems to matter also related to function. And we found quite strong correlation both for the fractured leg and for the non-fractured leg related to fast speed walking at time of discharge in the acute hospital. So it seems to matter. So what to do about it? Well, there came some new data today in Cochrane review and meta-analysis, but I didn't know that, and I think they just support, at least the one Sherrington reported, that clinicians can be confident that greater improvements in overall mobility is possible with progressive resistance training. So talking about that, then repetition maximum, if you do strength training, it's an important thing to focus at. And it was actually defined in 1945 by Captain DeLorme, a long time ago, but it's a brilliant paper and very informative reading related to how to practice strength training. But later on, it was giving a definition that the maximum number of repetitions per set and can be performed at a given resistance with proper lifting technique, and that's also important. The last one, I think he didn't include that in his definition. So, and repetition maximum, if you read the literature, many studies report, well, the strength training was practiced with 75% of one repetition maximum. This requires that you actually establish what is one repetition maximum, and it might not be that easy. And the challenge is, how often can you do that for if you want to progress your weight loads along the training program? So, but you see that it's quite common, but for daily clinical practice, it's difficult if you have to reassess one repetition maximum all the time. So if we say we want to train with 75% of one repetition maximum, you might as well just say we will make 10 repetition with a 10 repetition maximum. So you will, from set to set, be able to adjust the weight loads according to what you meant to do. And with that, I'll give the word to Lisa, who will follow up on this. So, Lise Kronborg was a PhD student at Hvidovre Hospital and is now a lecturer at the University College Copenhagen. So, welcome to you.
Thank you very much. Here we go. Yes, I will continue on this acute phase, looking into how to conduct progressive strength training during that early phase. Do we have? Yes, we do. Just to set the scene of what the course is like in Denmark, we have here the scheme saying that when you have a fall and a fracture, our patients would move directly into the acute ward where they would receive acute rehabilitation for about the first week after surgery. After that, the majority of our patients would be discharged directly to their own home and receive their rehabilitation as home exercise or based in a community center like outpatient rehabilitation. And that would continue for about 6-12 weeks, something like that, which Jan will dig further into. But we are now in the acute in-hospital rehabilitation phase. Some years ago, we had an idea that strength training would actually be able to counteract that strength deficit that Morten already explained, that we see directly after hip fracture surgery. There is a number of negative factors affecting these patients at that early point. And we see it displayed in the strength deficit. So we had an idea that despite all those negative factors like pain and edema and all that stuff, we'd still be able to counteract that strength deficit by applying strength training. So that we would be able to read a smaller difference between the fractured and the non-fractured limb. And we also had an idea that it was the more the merrier scene, so that the more strength training we applied, we'd see a larger reduction in that strength deficit. The dose we settled for was, for a reason that Morten explained, 3 times 10 repetitions at an intensity of a 10 repetition maximum, applied once daily, starting as early as possible, meaning from day after surgery. We tried it out in a couple of studies. One was a feasibility study on the method itself, and the other was a randomized trial on efficacy of this method. What we found, and what I think you could be able to expect, was that we were able to take on this, our patients were able to take on this strength training at a very early stage, like 2 to 3 days after surgery. Having in mind that in this setting, the day before was taken up by a strength test. So in your clinical practice, you should actually be able to start even 1 day earlier. Our patients, they received during their acute stay in the hospital 5 to 6 sessions during their stay, and they had a progression in weight load at more than 3.5 kilos from start to end. As you see here, there will be more than 70% increase in weight loads during their course. That is quite a lot, having in mind that these patients are 80 years in average. That's quite a fair increase over such short time span and so few sessions. There was a quite high compliance with this method, even though we were at this very acute stage. We were working with quite good strength or weight loads on the fractured limb alone. 80% of all planned sessions were completed, and the main reason for not completing sessions were pain, exhaustion, or nausea. We like to do things systematical, and since pain was such a large factor in the matter of completing this method, we looked into the pain score, and we used the verbal rating scale, a 0 to 4 rating scale, including the patient's best description of their present pain. As we know that numeric scales might be very hard to operate for this population, hard to say that my pain is 4 or 5 or something like that. It might be easier to say if it's light pain or moderate pain or severe pain. So that was our way of systematic registration of pain in this setting. We were also quite systematic about reporting or registering, administering the strength training. We used a chart like this, where you see a lot of variables, which day we started, accumulated ambulation score, and so on, reported for every patient. And we would have here on the chart the pain score, and we would also have registration of the limiting factor. What would limit this patient in case the patient were not able to complete the session as planned. And you can't see it, but down here we have a number of different factors, limiting factors that would be pain, motor block, dizziness, fatigue, on and on. So we would know what is the cause here for not completing. And then for each session, we would note the reps, repetitions, the kilos, the weight loaded. We would note the pain score for each set, and also the limiting factor in the scene that it was not completed. In my opinion, as a clinician working with people at this early stage, I think this is the only way to be able to progress strength training sufficiently, going set by set. If you go more than 10 plus 2 repetitions, then you must load. If you wait another day or another day to load this patient even more, you would lose that intensity needed. So this is the way to progress, set by set, session by session. And I'll show you, it's much easier to show. So I'll just I'll try to speak a little louder, but please say if you can't hear me. This lady was unfortunate to have a fall and a fracture in the femur, and we are now in the acute ward. What we're looking at to do is this, which is published in the feasibility paper. We now have Mrs. Jensen here on the bedside, and it's important that it's actually bedside, because you see this is the setting in the acute ward. We have a bedside, we don't have a power rig, we don't have it. It's hard to transfer this patient to anything else but the bedside day after surgery. So this is it. This is what we have to do with. Yeah. Will that do? Okay. Great. Now we have the fractured limb here. What I want to know is how much to load. I'll then just get on forward, because this is the scheme of what I'm doing. I'll go here in just a second. I'll show you, and then I'll go through the scheme. Can you hold your leg here? Mind you, this is the fractured limb, and you have a very painful leg here in some way. Yes, you can. Can you lower it down? Thank you. And stretch again. Thank you. Slowly. Thank you very much. This gives me a good idea of what is the activity like in this body test. And that's what I'm interested in. It looks to me like we could do something about this. And I have the patient on the bedside, and have the non-fractured limb resting, so we have a good rest here, and we have the hands supporting the bed, and we want the patient to be in a safe position. But this is, there we go. No, what we want to do is have a lot of time under tension, so we don't have any rest under this leg. We want some activity here. So what we're doing now is contraction modes: 2 seconds isometric, 3 seconds eccentric, and 3 seconds concentric. And it looks like this. Can you hold your leg here? Thank you. 1, 2, lower down. Thank you. 1, 2, 3, come back up. Thank you very much. And continue. 1, 2, 3. 1, 2, 3, hold. 1, 2, 3. 1, 2, 3. Thank you very much. And you can continue as many times as possible, because I want to see what what intensity we're working at. If I told this nice lady, thank you, can you do 10? I would have 10. So I wouldn't know if that was sufficient intensity. So when I come up to more than 10, 10 plus 2, okay, I need to know more now. You did 15, oh, that's very nice. You have your 2 minutes rest now. And in the meanwhile, I would ask, do you experience any pain here? Yes. Yes. Oh, that is bad. Was it light pain, moderate pain? Moderate. Thank you very much. And I will note that in my chart. 2 minutes gone. Are you ready to go again? Thank you. I'll lift the leg. Can you hold again? And lower down. 1, 2, 3. 1, 2, 3. Hold. 1, 2, 3. Continue. Thank you very much. And also, I said contraction failure in each set. That means going as far as possible. Can you take as many as possible? Thank you. If I didn't ask that question, I wouldn't get to contraction failure. I'll just get what I asked for. So this is what it means when you do progressive strength training at this early stage. Thank you. Good. And my our sort of plan is 10 repetitions plus minus 2. If you get 10 plus 2 or more, when you say, can you do as many as possible, you progress every set, not every day, every set. If you get less, you need to do the same or regress or diminish your weight. Yes. That was it for acute setting. Now we hand over to Jan to continue.
Thank you very much. Thank you, Lise, and thank you for letting me present some results here today. I'm a clinician working in the community.
I have a bit trouble calling things in English. Is it community and municipality? Right now I'm stuck with municipality, but whatever. This is where I work. And to set the scene, we are going to look at the patients when they get discharged out into the community-based rehab. And about 90% of patients in Denmark get discharged to their own homes within 7, sometimes earlier, 5 to 10 days after surgery. And we provide transportation for them in order to get into healthcare centers to provide them physical therapy, often twice a week. And if the patient is not able to come into the center due to low ambulation, we do the home exercise with them in order to get them fit enough in order to get into the rehab, the rehab center. So when to start progressive strength training? Of course, Lise just mentioned that is something that you should do straight away after surgery. With the component of progressive strength training, there's only 2 other studies looking at this at an early time point. The Howard study was, I think, about 30 days after discharge, and the Mitchell study was 16 days after hip fracture surgery. So we wanted to try this out in the community, in the municipality, try to do the progressive strength training as shortly after hip fracture surgery as possible. And please bear in mind that this study was published back in 2013, way before Lise was commencing her studies. So we thought it was quite novel, and we wanted to challenge the, as Lise mentioned, in the literature it's often mentioned that you have to do every second week, you have to make a measure like 1 RM, as Morten mentioned, in order to get the proper weight loads. But we wanted to challenge that and do the progressiveness in each set of the progressive strength training. And we also wanted to look at if hip fracture-related pain influenced the progressiveness of exercise and also in the measurements. Please bear in mind that this is a non-randomized feasibility study, and it was conducted in 4 municipalities in Denmark. It consisted of 6 weeks of training, 2 times a week for 60 minutes. And patients were included almost 18 days after hip fracture surgery. It consisted of 60 minutes of structured exercise. We had warm-up, functional training, balance training, and of course, progressive strength training. We used the bilateral leg press, but also just the fractured knee training in order to diminish or reduce the strength deficit between the fractured and the non-fractured limb. And this is kind of like the protocol that we followed the first 2 weeks, 3 times 15 RM with intensity of 15 RM, going to the last 2 weeks with even more intensity, but at less repetition maximums. So hopefully this is going to work. I have a small video that I'd like to show you. This is quite interesting. A patient who fell while he was walking with his dog. He was living all over the world. He had a career as a mechanical engineering, ordering into the mechanical engineering, ordering oil drilling business. He has some lung fibrosis, but he was doing okay. So this I'm going to show you is that in his second week of training, and I'm only going to show you the bilateral leg press because Lise already showed the unilateral. Yeah, this is how it's working. Could you help me, please? Of course, this is in Danish, but pay attention to, he should do like 15 RM or 15 repetitions in his, and this is in his last session, before doing some more weight, increase in weight loads. Also pay attention to the physiotherapist who is doing a lot of verbal encouragement on the patient. That's why I'm only going to show you one video because it's coming. Yeah. So the physiotherapist is going to push the patient a little bit on the cart in order to get him started, because there's takes a lot of energy to start the exercise. Well, okay. It's a long connection to Denmark, so sorry. 1, 2, 3, and no. That was number 3. It's going to take 15. That was the program protocol for this time, the session. And he's under pressure, right? He's doing everything he can. It's number 9. Okay. Come on, you can take some more, it says. Come on. And he pushes him just to get started. A little bit closer, he says. Come on. So he did some more, right? So that was Lisa was talking about. Not just tell them what to do, but tell them they have to do as many as you can. That's the key word in order to get the progressiveness into this session. Oh, that was the wrong one. I might need some help again. And sorry? Yeah, can't read it from here. Oh, there you go. Yeah, it's in English, sorry. Yeah. Now it has to go back to Denmark again. So. So, as Lisa mentioned, you have to be systematic when you do this progressiveness in strength training on a set-to-set basis. You have to take into account if there's any pain, but also limitations, if there are some limitations during the progressiveness of increasing weight loads. So, some results. How much did the patient progress during the 6 weeks of intervention? I must say a lot, especially within the first 2 weeks. We had an increase in the bilateral leg press of over 80% over 4 sessions, and over more than 50% in the knee extension strength training. So for you in clinical practice, you have to be aware that you have to push the patients a lot in the first couple of weeks in order to get them up to the beat where they have to perform as much as they can. And we reduce the strength deficit from between the fractured and the non-fractured limb from around 40%. We measured around 40% when we started training in the municipality. Morten mentioned 50 when they get discharged, so there's a little bit of increase there. And we reduced it into 17%. We're still persisting after 6 weeks of exercise. And you might think, how about pain? You must have a lot of pain when you get training like that. But at baseline, actually, during the progressive strength training, most patients didn't have at least no or light pain during the training exercise. And after 6 weeks, oh, sorry, and after 6 weeks it was kind of like similar, but more than had less pain. I must mention that we did see some knee pain in some patients because we didn't monitor if they had some OA problems in their knee, but they were actually performing quite well and were walking longer distances in the 6 minutes walk test when we tested them at 6 weeks after 6 weeks. So in conclusion, this is a combined conclusion of all the things that we have presented in this session. That progressive strength training can be commenced in the acute ward and continue afterwards in the rehab setting after discharge. The 15 to 8 RM approach is directly applicable in daily clinical practice without any sub-calculations. That's why we love it out in the clinic, and allows a progression on a set-to-set basis. We didn't see that hip fracture-related pain had any influence on the strength training. And there was still some strength deficit after 6 weeks. So I just want to acknowledge all the funding that have been supplying our studies in order to get them done. And yeah, thank you very much.
Okay, we'd like to invite back the Danish group. And I'm not sure I want to break my hip in Ireland or in Denmark, haven't seen that. But maybe I'll definitely be stronger maybe if I go to Copenhagen. So if we could have 3 speakers and we'll take some questions from the floor. From the back, Maria, thank you.
No, unless if there's any restriction, which is rare after surgery. Other than that, no. All fits. All.
I think so. We have it's like 2%, about 5% at the most that are not allowed. Weight bearing is tolerated. So it's yeah, it's the standard procedure.
Okay. Another question from the floor. If you could just say who you are, where you come from, great.
Where to draw the line with the pain scale with progressing resistance? So what point to say, okay, this takes too much, we won't let it anymore?
In the acute setting, it would be severe pain. To me, severe pain. Okay, we end the session.
Yeah, it's the same in outpatient facility. Yeah.
So related to this question, so then if you decrease amount of weight or amount of repetition, you will continue with 10 repetitions plus minus, but you will weight.
Yes, we stick to the same dose, but yeah, increase or yes, keep the intensity by increasing weight levels.
And one more question, because obviously you are doing frail people. Are there any contradictions to take into account?
Contraindications. Any?
No, no.
We didn't experience any hip crashes or anything.
No adverse events.
Actually, I think I was not the one doing it, but I heard you just reporting they actually liked the patients because they could really feel this there's something going on. This is really hard, and well, so I think.
And yeah, to add to it, well, what we see early in the acute phase is that weight bearing might be hard, walking might be hard, but sitting bedside doing a knee extension, that might be the possible thing to do at the early stage. So we can sort of not replace functional exercise, but we can certainly add on and maybe do that on very early days where walking isn't actually sufficient or possible.
Another question here. Thank you.
Do they have to be able to do full knee extension without weight?
No, we would allow up to 45-degree deficit. Yeah.
Okay.
Yeah.
Any other questions or any queries? Any other from the floor? Yes.
The ones that stay at home, how do you take the weights then?
Normally, we try to get them, the basic mobility things like getting in and out of bed, up from a chair and being able to walk with 1 or 2 assistants, by some assistant. And when they can do that, we try to get them into the community center, because we can push them much more harder than doing the ankle cups back home. So as soon as it's possible, we take them into the healthcare center. Yeah.
But still, I think that the simple way with the weight loads, if the physio is able to carry the weight loads out there, then you could practice also at home. It's very basic, so it's possible. And you might find other solutions than specific weight loads.
Okay. Okay, any other final comments, or just on the general session in relation to exercise? And yes, Kathy.
With the device to stabilize the hand going monitor.
Yeah.
More about it.
I made it. It's a simple strap with a long, heavy resistance, or actually Velcro band, something like that. Long, strong.
And so what's it attached to at the other end?
It's attached to itself. You do it to the bed frame, so you attach that. It has a Velcro also that fits on the dynamometer. So you have the device fixed with the strap around the bed frame.
Actually, we tried, before starting the study, we tried different options. I actually had a box made where one was sitting on, and then the dynamometer was applied between the leg and the box. But the strongest patients with their non-fractured leg, they could move the box, at least with me on it. So, and that's why we went on to the other, which already was used by some of our colleagues, but not in this patient group. So, yeah.
And also there's going to be a presentation Thursday by me on the reliability of that measure. So, okay. So, yeah.
One last question here, thank you.
How are you going to compare this kind of exercise for the leg to sitting stand or standing position?
Oh, good.
As an intervention? As an intervention?
Yeah.
Yeah, we could do that. Yeah. I think the challenge is in asking people to do a lot of sit to stands is that many of them experience hip pain doing that. So that's why we choose the specific knee extension, which not directly involve the hip.
Yeah, but I would guess you could put some more weight loads on them and do like in the. Yeah, you can do some cups. Yeah.
Okay. Thank you very much, everybody. Thank you. I suppose it just highlights again, I mean, we are the profession who drive exercise, I think, in the clinical place. And it's really critical that we document what doses we're giving, and that we know the frequency, intensity, the type, time, and that when we do our trials and our research, that it's evident when we go to our papers. For any of you who've been reviewing the literature, often this is really absent, where there are physio, not just physio interventions, other people who deliver exercise trials too, failure to really document what kind of dose is it that makes the difference. And I just think congratulations to all our speakers. I think it's been a really worthwhile session, and it's time for a break. Thank you.